Service Innovation is an experiential, project-based course at the Stanford Graduate School of Business. In this course, students came together from diverse disciplines at Stanford to design services that meet real-world needs. The course is grounded in the design thinking approach to innovation that emphasizes empathy building to deeply and accurately understand users' needs and build creative solutions to address them. Students have partnered with safety net hospitals and clinics in the Bay Area and other healthcare organizations that serve the underserved populations.
We're going to start off our presentation with a short story about a guy named Greg. Greg is a middle-aged man who lives in a cozy little home in Alameda County. He's got a 9-to-5 job, works 5 days a week, and he usually comes home after work and watches a little TV. One day, he comes back from work, and he's feeling kind of sick. He's having a little bit of trouble breathing, and he's getting kind of worried. So he gives his primary care physician a call, and basically a nurse picks up and tells him that they're booked 4 months out, and that if he really needs to see a doctor, that he should go to the emergency department. So Greg tries to wait it out, but he's getting really concerned. So he ends up going to the emergency department, and he waits for a really long time, about 3 hours, until he finally sees a doctor. When he sees the doctor tells him he has asthma, but he gives him the correct medication, and he's fine. So Greg's story right here ended up just fine. Greg's okay, but if you zoom out from this story, it turns out that there are thousands of people like Greg in underserved communities like Alameda County. And this is where our partners come in, or in this case, Chelsea. Chelsea works for the Alameda County Healthcare Services Agency, and she's working on a project to increase healthcare access points for people like Greg in underserved communities. And the concept that they are trying to develop is to integrate clinics with fire stations. And so right now this project is pretty early stage, and what they're looking to do next is develop a customized list of services that this fire station clinic will offer. And basically where we come in is we want to address that need by creating a tool and method for our partners or Chelsea to use to determine scope of services or a customized scope of services for these fire station clinics that are going to be in these communities.
So as Ian alluded to, for the Fire Station Healthcare Portal, as well as for many forward-looking healthcare initiatives and organizations, focusing on the local community is very important. And this aligns well with our human and user-centered design methodology. So what we started out by doing was just getting to know the community. We visited the firemen, we talked to them, saw what they wanted out of the project, what their concerns were, where they lived. We visited other health centers around the area to understand what other services were available to the community. We got some vaccines and blood pressure measured ourselves. Really just walked around and tried to understand what the community was like and what context our solution could be placed in. And we realized that if the healthcare portal is really going to address the needs of the specific community that they're trying to address, then really the services have to come first. Because having figured out the scope of services, then the clinic layout, the process flow, and the patient flow all come from that. So this is what we came up with. It's called Service Scope. It's a tool, it's a comprehensive tool that allows people like Chelsea to take in different considerations that are important in understanding what the community needs. So it takes in different axes things like potential severity, the cost to treat or diagnose or screen, the legal risk incurred, and other considerations that are important. Not only is it comprehensive, it also is very community-driven, which is very important. All the data that ServiceScope takes in is from the doctors, the nurses, the paramedics, and other healthcare professionals living in that area, as well as the community residents, which is fundamentally different from researching national averages and agglomerated data and assuming that all underserved communities have the same problematics. ServiceScope is also a good tool because it allows the either Chelsea or the person implementing the clinic to figure out up front what the community needs instead of understanding through time and suffering from financial losses or potential patient dissatisfaction. Additionally, service scope is flexible.
So now that you've gotten a very basic general understanding of service scope, what we can do now is we can bring service scope and we can give it to people who are looking to create new healthcare centers such as Chelsea. Chelsea takes this, and Chelsea knows that it's very important to understand the community. And Chelsea, like other healthcare center creators, all know this. But currently, there's not a methodology to get all of this feedback. What a lot of people use now is they perform interviews with doctors, with community care centers, and also with potential patients. They also can use surveys, or to a greater degree, they can also call for community meetings. But all of these provide very qualitative information. So currently, there is no method for quantitative information to be brought back from their communications. So this is where service scope comes in. Service scope provides a physical product for Chelsea to bring with her during all of her interactions with the community members that she finds important. This is a picture of us actually taking service scope. It's a little different from what you saw because it's our earlier generation model of service scope. But we took this into the community. We talked to doctors who actually served Alameda County, as well as doctors who specialize in emergency medicine. And so in this picture, this is us testing the prototype just as Chelsea would do in the future with a doctor. This doctor in particular specializes in emergency medicine. And what's so great about service scope is that it's very flexible. So what we could do is we could readily change the axes for service scope to directly address the expertise of this doctor that we were speaking to. And so because he specializes in emergency medicine, what we asked him to rank was time spent in an emergency department versus cost to the emergency department, or other things such as the severity of the condition when it's seen in the emergency department and the time that it takes out of total emergency department visits. And so with this, Chelsea can now go and talk to as many different people as she wants with a very specific set of axes for each specific person that she talks to. All she needs to do after her talk is complete is to take a picture of the final product and input it into our Java algorithm. So basically, the picture gets loaded, and by simply typing in the diseases or the services of interest, a colored dot with that disease labeled will appear, and she can easily click and drag that to the appropriate marker on the board. When she completes this for all the relevant services, she can then define the area of interest in her quadrant that is specific to her clinic's model. So in this example, we decided that Chelsea wanted something of low legal risk and of medium required expertise. And this is marked by these 4 orange dots. Then simply by pressing write out XYZ file, all of this gets inputted into an easy Excel output, which Chelsea can then paste into our Excel algorithm. All she needs to do now is assign an axes weight to that specific set of axes, which was legal risk versus required expertise. And she does this for all of the relevant axes and interviews that she conducts.
So our current tool is a Java-based application for input that flows and gets pushed into an Excel-based spreadsheet, and that kind of gives you a top 10 list of diseases to focus as your service scope. But there's a better way to do this, and we're looking into the future of what are the potential options. The 3 things that we need to address are how to further integrate our tool so that it's not multiple pieces having to be pushed multiple times. The second thing that we need to improve is the accessibility of our tool, so get users to actually use it. The third is to increase the ease of use. So we think that using a web-based application is one way to do that. A web-based application would be able to not only accept the input, but also do the calculations and spit out the top 10 list of services. The second thing that it offers is you can simply click on the website instead of having to send a Java-based tool via email. And the third thing is the user doesn't need to have a Java in the proper, I guess, level installed on their computer. The second thing we wanted to do was to offer an app. So what this also allows beyond the integration is, since there are a lot of doctors right now with iPads, since there are a lot of customers with mobile phones, smartphones, they can more easily use this tool by simply dragging with their finger to where a disease would fall in this quadrant. So it increases the ease of use. So where do we go from here? We're at the end of our class, and the next step to do is to test with more medical professionals, to test with the community what the community really needs. And 3 is to define the algorithm. Once you do these 3 steps, it kind of bifurcates into two areas. One is to develop the actual fire station health portal. So taking the scope of services, taking that into a process design, architectural design, and final implementation. The second thing to focus on is the product development. We see that the final product and the final output would be, a web-based app that we could potentially partner with a nonprofit organization focused on community health. And they would be able to send their clients and redirect them to our tool. Our tool would be able to provide, potential new developers a scope of services, which with it, a scope of services that they can offer their specific community. Or in the future, what can happen is that the community can actually be the ones that are empowered. They can say, these are the top 10 things that I go to the doctor for. And we have that data in aggregate so that you come in as a new developer and you already know what the community needs. So that's where we see the future of our tool. The way we see our tool being offered is kind of a freemium product. We would offer this service to anybody who wants it to develop their top 10 list of services. And then potentially in the future, we would redefine and or add more value to our product by saying not only are these the top 10 services that you should offer, but what does that mean in terms of dollars and cents? These top 10 services, how long does it take to treat cancer? How long does it take to diagnose that you have a UTI? Who can diagnose it? And to be able to quantify in dollars and cents what this top 10 list of services actually means. So with that, I would like to thank everybody for being here. I would like to thank Kristel from the Fire Station Health Portal, and I would like to thank our teaching team. So I would like to open it up for questions.
Good job. I mean, first of all, for all the groups, I've been so impressed with how polished your presentations are. I mean, I only heard a handful of ums, and it was just fabulous. Well done. Quick question, just maybe a clarifying question. As you think about physicians trying to, or whoever's putting in the data, and you think about their level of understanding of how much things actually cost, how important is it to be precise versus, approximately accurate?
So I think the purpose of this tool is not to get actual hard data, because then if we want to talk about it in that way, then it's probably better to get the facts and the figures from actual sources. The importance of this with the physicians, it's in their view. So for example, when we ask, how much do you think this is to the emergency department when you're doing it? It's a way to get their feedback in a way, so that feeds more to the community-centered aspect rather than to the actual numbers.
So then as you think about the individual that puts it in after that individual inputs a lot of data, will you have to weight their scores, so even if he's off by a quadrant relative to his or her?
So ideally we get enough data where that would be the average out. Yeah.
Interesting. Oh, that's good.
I think it's a terrific way. Anything in healthcare that takes complicated data or data that people are reluctant to share and presents it in a simple way. This is a great way of doing that. It's a prioritization tool for communities and folks looking to open these clinics, which is awesome. I like Tom, thought a little bit about the integrity of the data, because there are some conditions or diagnoses that are very simple. So non-compliant COPD or diabetes, and pretty straightforward. And I think most providers would be able to assess it and what time it takes or cost. But then you get, these diagnoses like chest pain that every provider is going to have a different approach depending on what their training is, their specialty, what type of patients they see. So you could get a huge skewing of the data, and it'd be standardizing by taking the arithmetic mean may not be the right way to produce high quality data. So I wonder what you can do to, because the questions you ask and the fields you choose is going to be very important to how strong your data is. And I wonder if there's a way to tighten that up a little.
And I had a question, just sort of thinking about, I think it's fantastic, and I think getting I just know specifically on this project, but on lots of projects like it, getting the community input from lots of different people about what the service priorities are is really important, and it's not something people do well or in a kind of consistent fashion, so that's terrific. I'm curious about whether you guys have contemplated, or in the course of this project, have actually gone so far as to say, here's what the community is saying the needs are, here's what the resources that are already out there are, here's what we know we have a shortage of, and how well does that match up with what people are saying they need more of? Have you guys used it in that way, or has it been are you thinking about this as the community input part of it, and you'll then later do the analysis about, we know that there's already plenty of this service available, so we've clearly got a mismatch problem. People aren't aware, people are saying we need it, but we know that's there, versus a situation where, we know we need more of this service, people in the community say they need it, so if we build it, they'll probably come. As opposed to you've already got somewhere, you've built it and they're not coming. So have you guys thought about a way to integrate the desires with the actual data about supply? So that if they build it, people will come? Because I think that's the biggest challenge with this project. If you build it, will they come?
I think one of the other directions we wanted to take this project in was exactly that, addressing the need of filling in the gaps of what's not already there. And to do that, one of the ideas that I think Stafanos came up with was when we had the little push pins to color code them. And so, for example, red push pins would indicate that these services are already offered in the community. And so we did go in that direction at first, but pursuing that required getting a lot more data, which we didn't have time to do.
And I'm from Alameda County and the project director for this particular pilot. And I really want to commend you all for the work that you're doing, because we ourselves are trying to figure out what our scope of services is going to be, and it's very unclear because the model that we are trying to implement is quite new and innovative. So our thought is that we would try to take the retail clinics that you find, for example, in Walmart or some of the other pharmacies that are putting together these sort of low acuity condition clinics. We wanted to try to take that idea, bring it over to fire stations where we know that there's a good amount of community trust already. In particular, there's a lot of people who are using emergency medical services as their primary care. And so we wanted to try to co-locate those kinds of clinics at the fire stations. But at the same time, we didn't want to just leave it at the retail model. I mean, one of the drawbacks of the retail model is there's no connection to a medical home for long-term care. And because of our particular population, they're quite vulnerable. We want to make sure that the community is well served and that their needs are being met. So that was the challenge that we posed to these students. And I have to say that this is probably the best tool that I have seen in terms of getting actual input both from all of these different stakeholders. So I can't wait to be Chelsea and do the thing. Thank you.
Great.
That's great.
Thank you. That's fantastic. Yes, that's it.